Good afternoon, everyone. Welcome to Concord Hospital's Trust special programming of What's Up Doc. We're very excited to have you here, and it's great to see the numbers kind of increase as people get more comfortable. It's a beautiful December day, sunny but a little chilly. We want to take this opportunity to thank the Walker Lecture Series for their terrific and generous sponsorship of What's Up Doc. The Walker Lecture Series was established in 1896 as a result of a bequest in a will. And the great thing about the Walker Lecture Series is it's open to the public, and all of their performances are free. They offer literary performances and things on science, history, art, education, all kinds of things. So we encourage you to take a look at their website and their schedule of programming and take advantage of it. Their shows are in the Concord City Auditorium, and as I said, they're free. I'm very excited to present today's speaker. Dr. Desmarais and I started, I think, about a year ago talking about him coming to What's Up Doc and being a presenter. Of course, he's got a very active and busy practice, but we finally were able to settle on December of this year, and I think it's great. I don't know about you, but my knees hurt a lot of the time. So I'm looking forward to hearing Dr. Desmarais' presentation. I just want to let you know that Dr. Desmarais graduated from Tufts University of Medicine in Boston, Massachusetts. He went on to do his residency at the Tufts Medical Center, and then he completed a fellowship in adult reconstruction of the hip and knee at the Hoag Orthopaedic Institute in Irvine, California. Dr. Desmarais is from Concord Orthopaedics, and he joined our system in 2020. Please join me in welcoming Dr. Jason Desmarais.
All right, so thank you all for coming. I appreciate your time. So my name's Jason Desmarais. I'm a board certified orthopedic surgeon from Concord Orthopaedics, and I'm here today to talk to you about hip and knee arthritis and some of the treatment options that we have. As she mentioned, I actually grew up down the road in Manchester. I was born at Concord Hospital a while back. I went to Central High School in Manchester. Went to college in Worcester at Holy Cross. Did my medical school at Tufts in Boston. Stayed there for residency, and then spent a year specializing in hip and knee replacement out in California, and then made my way back to New Hampshire. So I'd like to keep it informal today, so if anybody has questions along the way, feel free to ask, and I'm happy to answer anything that comes up. But I primarily specialize in hip and knee replacement, specifically with hip replacement, direct anterior hip replacement, which some of you have heard about in the past, knee replacement, partial knee replacements, and then redo, or what we call revision hip and knee replacements when they fail, redoing them over again. I primarily do surgery here at Concord Hospital. We are doing some surgery at Laconia Hospital as well, and at our orthopedic surgery center where patients come in and go home the same day. So today I'm going to talk about arthritis in general, really how to assess your pain, some of the treatment options that we have, both non-operatively and operatively. We'll focus on the hip for a little bit, talk about some of the causes of hip pain, some of the treatment that we have for it, and some of the recovery that goes into hip replacement. And then we'll also focus on the knee, some of the causes of pain, how to make the diagnosis, some of the treatment options that we have, and what recovery for a knee replacement looks like. And then we'll go over any questions you have as well. So what's causing your pain? Arthritis is extremely common. About 70 million people in the United States have arthritis currently, and that number just continues to grow. Osteoarthritis is the most common form of arthritis, and it's really just a wear and tear of the joint or the cushion in your joint. And when it wears down, it becomes arthritic, meaning that the bones start to rub on each other. It causes pain, inflammation, and reduced range of motion. It's a degenerative condition, meaning that it doesn't get better typically, and it might slowly get worse over time. Then there's rheumatoid arthritis, which is kind of a different category, but it's when your autoimmune system kind of attacks the lining of the joints, and it also causes arthritis. Sometimes this can be treated with medications, but it's primarily worked up through either a rheumatologist or a primary care doctor with blood work and tests like that. Sometimes it's treatable with medications. As I mentioned, arthritis is extremely common. The U.S. population is aging, and 1 in 5 adults nowadays have arthritis. In the next 10 years, it's estimated that over 60 million patients in the United States are going to have arthritis, and over 25 million people in the United States are going to have mobility issues because of arthritis. So it really affects people's quality of life on a daily basis. And it's almost primarily osteoarthritis, which is accounts for more than 90% of all arthritis across the board. It has a strong correlation with a few risk factors. 2 of those risk factors are obesity and diabetes. As I mentioned, the population's getting older. We're also getting heavier as time goes on. Those 2 factors really contribute to developing arthritis. In patients with obesity, over 50% of them have symptomatic arthritis. Diabetes also plays a role in this, and that kind of goes hand in hand with the obesity epidemic that we're dealing with. But if someone has obesity and diabetes, there's an over 50% chance that they have symptomatic arthritis. So some things you can do to assess your pain. Does it hurt when you walk? Does it hurt when you put on shoes and socks or do normal daily activities like go to the grocery store? Does it limit what you can and can't do? Does it affect your balance, or does your knee or hip give out on you? Do you have pain in your hip, your knee, your groin, or just throughout the entire lower extremity? Does it radiate to the knee, or does it keep you up at night? These might be signs and symptoms of arthritis. So a couple things you can do to assess your own pain. Does it hurt when you walk, or when you bend over to pick something up off the floor? Putting on shoes and socks is kind of a hallmark symptom of hip or knee arthritis. Is it difficult to get in and out of the car, or walk at the grocery store, or swing a golf club, tennis racket, pickleball, which is now the fastest growing sport in the U.S. Some of these things may cause pain, and it might be due to arthritis. So when we think about treatment options for arthritis, they kind of fall into 3 different categories. There's medicine or non-pharmacological treatments. Those include things like exercise. Physical therapy can sometimes be helpful. Weight loss, and just patient education on altering your daily activities. When that doesn't work, we start thinking about medicines for arthritis. Some of the most common medicines we use on a daily basis are medicines such as Tylenol, anti-inflammatories, and when taken consistently, they can be actually pretty effective. And sometimes we have prescription strength medicines for this sort of thing. We rely on non-narcotic medicines to help treat the pain. There are also topical medicines. There's anti-inflammatory creams or gels. CBD oil is getting more and more popular. It's hasn't been studied in depth, but I have a lot of patients that use that, or turmeric or cumin and things like that are more natural kind of medicines. And then there are joint injections. I'm sure many of you have heard of a steroid injection or corticosteroid injection. And that's a medicine that goes directly into the hip or knee joint that can reduce inflammation and help alleviate pain. When all of those things fail, we start thinking about surgery for arthritis. And really the only predictable surgery for arthritis is a hip or knee replacement. Patients often will ask about a cleanup or removing bone spurs, and over time that's been found to be not helpful at all. And so, the end of the line treatment for arthritis are hip and knee replacement primarily. So I'm sure everyone in this room probably knows someone has a family member or friend that has had a joint replacement, and that's because it's extremely common. These days, there's probably just over 1 million to 1.5 million joint replacements done in the United States each year. And because of the aging population, that number might hit up to 3 million surgeries each year by the year 2030. It's been found to be one of the most cost-effective and effective treatments in all of medicine. And multiple studies have shown that for knee arthritis, a knee replacement has a 95% success rate, meaning good function, and alleviating pain and restoring activities. And back in 2007, The Lancet, which is one of the international journals worldwide, coined hip replacement the operation of the century. And in modern medicine, it's probably the most successful thing that we can offer a patient, and all across the board. So a lot of people come in asking, am I a candidate for one of these options? And number one, having x-rays or imaging that shows end-of-the-road arthritis is very important. And then we start to look at, patient-specific things like, are you a smoker? How's the weight? Is your diabetes under good control? Do you have a good support system? Things like that can be really important in terms of the recovery and having a good outcome. Not going through those risk factors and really getting yourself into a healthy position can really jeopardize the outcome of a surgery. And so we really focus on these things to make sure that we can achieve a good outcome. So we talk a lot about preoperative weight loss and conditioning before you have surgery. And this is for patients who may suffer from obesity or even patients that have a healthy weight. Because we've shown that getting yourself strong and healthy even before an operation makes the recovery much smoother and much easier. And so weight loss can be an important part of that process. Also, losing weight before surgery can really limit your risk of a wound healing issue, infection, the parts falling apart, or needing more surgery down the road. And so we found that with an arthritic hip or knee, it's really impossible to do this with exercise. And that diet modifications and changing the way you think about food and nutrition has really gone a long way in terms of reducing weight and making yourself a really good candidate for a surgery. We've also found that through nutrition, changing your diet has really had sustained weight loss, and it has a lot of really good effects, not just for the surgery, but just in general. Reducing inflammation, reducing pain, improving your mobility, getting your blood glucose or diabetes under good control. It helps with cholesterol. It's better for energy and sleep and just making you overall happier and healthier. Sometimes we'll refer patients to physical therapy. It's a good non-operative treatment option that we have. And what they do is they form a home exercise program or directed therapy in order to help reduce swelling, inflammation. Sometimes they can improve your range of motion and help out with your overall gait and balance. Even for daily activity things like teaching you how to pick things up off the floor in a better way, or getting in and out of the car and just doing normal stuff. Physical therapy can be really helpful, and this comes into play certainly after surgery, but even beforehand we'll often do something called prehab. Before you have surgery, you get some exercises and direction on how to make yourself strong and healthy before the operation. So for a little while, we're going to just focus on the hip. So just how your hip works. The hip is a ball and socket joint. So the ball is the top end of the femur bone, which is the thigh bone. The socket is called an acetabulum. It's on the pelvis side of your hip joint. And those two things articulate together. There's lubrication in the hip joint from the lining of the hip that helps promote normal seamless motion. It's got low friction, so it's kind of like ice on ice. When that wears down, that's what becomes painful. When you lose that cushion, it's another way of describing hip arthritis. So on the left is a picture of a normal looking hip. So you have part of the pelvis there. The acetabulum, again, is the socket part of the hip joint. On the other side is we call it the femoral head. That's the ball part of the hip socket. Then there's the neck of the femur, and that all connects to your femur bone. On the right is a picture of an arthritic hip. And so you can see that all the cartilage has been worn down, and it starts to form bone spurs, and it's a very rough surface. When those rough surfaces articulate, it causes a lot of pain, inflammation, and stiffness. So hip pain can come from a lot of different places. It's not always routine arthritis. It certainly can be, but not always. Sometimes you can develop tendinitis or bursitis, which is really just a fancy term for inflammation of the muscles around the hip. You can also have pain coming from the back that mimics hip pain. You could have something called a labral tear, which is it's a soft piece of cartilage on the inner part of the hip that can be torn. And then developmental changes in your hip. And we see that early on in life, not so much as patients get into their 60s, 70s, and 80s, but patients in their 30s, 40s, and 50s may have hip pain from the way their hip sockets didn't really form, quote unquote, the normal way. So we make the diagnosis oftentimes starting with an x-ray. It's 90% of the time this gives us most of the information we need. Oftentimes we'll get an MRI though if either the x-rays don't match up to the patient's symptoms or we're worried about some other process going on. But almost always we can get x-rays right in the office before the visit and take a look and see if arthritis is the problem. And making the diagnosis between arthritis or some of the other conditions I talked about will really help guide the treatment process going forward. So this is an x-ray on the left of a normal looking hip. You can see that the ball part of the hip is still a nice sphere. There's space between the two bones there, and that's a normal joint space. On the right side, that's what an arthritic hip looks like. The head of the femur started to flatten out, and you can see it's starting to flatten out. There's no space left at all between the two bones. And these are all a bunch of bone spurs around the hip socket. And the bone becomes sclerotic, meaning that it's a whiter appearance on the x-ray. That means that it's gotten harder over time because of the abnormal forces across the hip joint. All of these things are signs on an x-ray to me that a patient has bone-on-bone arthritis. So this is kind of another depiction of what that looks like. All the way on the left, that's a normal looking hip. In the middle, that's someone who has bone-on-bone arthritis. And this is a picture of a hip replacement. And I'll kind of go through what each of these parts of a hip replacement are. So when a hip replacement is performed, I'll go back one, basically removing the arthritic part of the joint, meaning removing the entire ball part of the hip socket or hip joint and reshaping the socket and implanting a stem inside the bone. And so we remove the ball part of the socket and reshape the socket. There's a metal component that gets placed inside the pelvis or the acetabulum. Inside of that socket, there's a plastic liner that goes in there. And then on the femur side, there's a stem that goes inside the bone. It's a metal stem. And then there's a ball that goes on top of the metal stem. And this is how your hip articulates and moves afterwards. Over time, the bone actually grows onto these parts so that they're stuck part of you for good. That usually takes anywhere from 6 to 8 weeks to happen. In the meantime, they're put in tight enough where they don't move and they don't cause any pain. But over time, we want the bone to grow onto it so that it stays where we put it. There are a couple different what we call bearing options, meaning what type of ball we use and what type of plastic liner we use. There's a metal ball and a plastic liner. It's not really used a whole lot these days. There's a ceramic ball and a plastic liner, which is what we use for 99.9% of hip replacements because it has the best wear properties. They last the longest. And then there's ceramic on ceramic. These were popular a number of years ago for younger patients because they didn't wear out. The issue is that they cause a lot of squeaking, and it's something that you can actually hear. And obviously patients don't like that. And so these days the ceramic on plastic is probably the best option, and it's like I said, 99.9% of hip replacements across the country are done this way. When we talk about hip replacement, there's a couple different ways that the hip replacement's done. And the first thing I would say is that putting the parts in the right way is the most important part. However, the recovery can be vastly different between the ways that the hip replacement's done. There are traditional hip replacements, kind of the quote-unquote old school way of doing them, where it's a lateral or a posterior approach, and there's more soft tissue dissection and removal of muscle in order to put the parts in. The way that myself and my partners all do hip replacements is through what's called an anterior approach, and it's been around for 10 to 15 years, and it keeps getting more popular for a number of reasons. But it's muscle sparing, meaning that we don't have to cut any muscle at all to do the operation. It's less invasive, it has a faster recovery, At 6 weeks, 3 months, patients with this approach are moving better, walking better, and have less pain. At a year out from surgery, there may not be a huge difference, but certainly, in the first few months there is a difference, and that difference is meaningful. There's probably a lower dislocation rate when the ball can pop out of the hip joint. We see that very rarely these days with this approach. And we're more accurate in terms of where we put the parts and how we look at leg lengths and making them symmetric. So it's done through an approach in the front of the hip. It's called anterior. The others are called lateral or posterior. As I mentioned, we can work between muscle groups and between nerve planes, and so we don't need to cut any nerves or muscles to do the operation. We also use a high-tech table that I'll show you a picture of in a second, which allows us to really look at the hip lengths and get them perfect, because we're able to use an x-ray during the surgery, so we know exactly where the parts are going, we know exactly how long they are and short they are, and make adjustments intraoperatively, and we have real-time data with an x-ray to tell us what we want to know. So it's done with patients lying on their back, and as I mentioned, the incision's on the front of the hip. This is the table that we use, and it looks crazy, but basically the feet are attached into these ski boots that are attached to the table. What it allows us to do is manipulate the leg in a certain way where we can do this approach without cutting any muscle and doing the operation very safely. The more traditional way of doing hip replacement, up until the last 10 years or so, patients were laying on their side, such as this. There's an incision on the side of the leg or on the buttock region, and it's a more invasive procedure with a larger dissection. We oftentimes need to use it when we have to do redo surgery because it helps facilitates a much larger exposure. We can see more. But I would say that the recovery is longer, and a lot of studies have shown that there's a higher dislocation rate when hip replacements are done this way. And x-rays are typically not used during the procedure, so there's a little bit of a guesswork with the leg lengths and using anatomical landmarks on the outside of the hip to determine how long or short it is. So I do think there's a lot of benefit to an anterior hip replacement. As I mentioned, smaller incision, less pain, faster recovery, lower dislocation rate, and essentially no restrictions after surgery. Before we get to that part, when someone's considering hip replacement or we have someone planned for a hip replacement, we always look at their x-rays, and we have templating software, and this is a picture of that, where basically the x-ray of the hip goes into the templating software, and we're able to basically plan out the size of the parts that we want to use and where we exactly want to put them, the different sizes and lengths, in order to restore the normal anatomy and give you the best functioning hip that we possibly can. And then during the surgery, we get x-rays of when the parts are going in. So on the picture on the left, it's an x-ray of the acetabulum, or the socket part of the hip joint. So we know exactly what angle it's going to be in and exactly where we want to have that put. And then the picture on the right is when the femoral stem is in, and we're looking at leg lengths and how far away the hip is, or the femur is away from the pelvis, so that we can match it up to the other side exactly. So this is an x-ray on the left of someone with very advanced hip arthritis. You can see this is a more normal looking hip, where on the right side, where there's space between the bones, and on the left, there's no space at all, and there's a cyst in the bone, which is fairly common to see with hip arthritis. And on the right side, that's a picture of a hip replacement afterwards. So there's the metal socket, there's a plastic liner in there with a ceramic ball on top, and the stem inside the femur bone. So a lot of questions come up about recovery and rehab after hip replacement. I would say it's really rare these days that we send patients for physical therapy after hip replacement, maybe a couple in 100 by patient request. And that's because you're able to walk on it right away, typically using a walker for a few days, and then a cane or crutches for the next few weeks until your balance and strength is returned. We want you walking on it 5 minutes every other hour for the first couple weeks, and then as time goes on, you're walking more and more, and the strength comes back pretty quickly, and you start walking pretty normal within 1 to 2 months. And so we found that physical therapy is an added cost to patients and haven't found a whole lot of benefit to it. And so we really will do it if patients want to or have specific needs, but it's not a routine part of our rehab protocol anymore. Some of the expectations after hip replacement, that the incision heals within the first few weeks, that you're walking, typically by the 4-week visit, walking without a cane. Some patients are still using a cane, but oftentimes not. And that the pain is gone, and that it just takes another month or so before you're back doing normal things again. And normal activities, looking at usually 2 to 3 months, sometimes sooner, sometimes later. But by the 3-month visit, 99% are back to normal activities. So now we'll focus on the knee. The anatomy of the knee is a lot different than the hip. So the knee is a hinge joint, meaning that it bends and straightens. It has a little bit of ability to rotate and translate, but for the most part, it's a hinge joint. The 3 parts of the knee are the femur bone, which is your thigh bone, the tibia bone, which is the shin bone, and the bottom of the femur bone and the top of the tibia bone are what articulate and allow you to bend and straighten your knee. And then there's the kneecap that sits in front of it. And then, of course, all the ligaments and everything inside the knee as well. So things that could be causing knee pain: arthritis or something like a meniscus tear. The meniscus is a shock-absorbing piece of cartilage right here that it helps absorb some of the compression of the knee. But it's pretty common to get tears in the meniscus, which can cause a lot of pain and swelling. Ligament injuries or tendonitis or inflammation of the tendons and muscles around the knee. Sometimes it can be a muscle imbalance between the hip and knee, or one knee to the other side. And once in a while, we'll see patients with only knee pain. Their only complaint is knee pain, and their knee x-rays look great, but the hip is completely arthritic. And so the hip is referring all the pain down to the knee. And it sounds crazy, but we see that probably once a month we do a hip replacement on a patient with just knee pain. And it's a challenging conversation, as you would imagine. And so in a healthy knee, the 2 bones articulate, they're covered in cartilage, and they have a smooth gliding with no pain. With arthritis, all of that cartilage has been worn away, and the bone ends are very rough, and they cause pain when the bones rub together. And that's what bone-on-bone arthritis is. And it's frequent to cause pain, stiffness, and swelling. So what's a knee replacement? It's somewhat of a misnomer. It probably should have been termed a resurfacing back in the day, because in reality, we don't take out the entire knee. It's a procedure where we resurface the ends of the bones and basically remove just the cartilage and a little bit of the bone and resurface it, and there are metal caps that go on either side. The metal cap up top is the one that goes on the femur bone, the one on the bottom goes on the tibia bone, and then there's a piece of plastic that goes in between that kind of serves as the new cartilage in the knee. And this is kind of what I just talked about, and this is how it looks inside of a knee. But again, there's the femoral component up top, the component on the tibia down below, and there's a plastic insert that goes in between them. We always leave the kneecap. Sometimes, and more often than not, we resurface the kneecap, meaning we remove the cartilage there as well, and there's a plastic piece that goes onto the kneecap. So all the way on the left, this is a normal-looking knee x-ray. The spaces between the 2 bones looks appropriate. There's still a lot of cushion there. The space is where the cartilage is. We just don't see cartilage on an x-ray. But by looking at that, I know that there's a lot of cartilage left because there's still a lot of space. The knee x-ray in the middle, that's a bone-on-bone arthritis knee. There's no space at all. There's bone spurs that have been formed there, and that's a diseased knee. And on all the way on the right is an x-ray of a knee replacement. Again, the metal cap up top and the tibial component down below, and the plastic is in between. You just don't see that part on the x-ray. There are some other options when it comes to knee arthritis. There's a partial knee replacement, and there are some candidates who are patients who are candidates for partial knee replacement. It's just not as common to see isolated arthritis in one part of the knee, but that's really what it's indicated for. If you only have arthritis in one spot of the knee, the other parts of your knee look perfect, occasionally we'll just do a partial knee replacement. There are some benefits to it. probably a shorter recovery time. The knee may feel more like a natural knee because we preserve more of the ligaments and tendons inside the knee. There are some downsides to it, though. If you go on to develop arthritis in the other parts of your knee that haven't been addressed 5 or 10 years down the road, then you could develop pain, and then we start to consider turning the partial knee replacement into a full knee replacement. So again, there's some pros and cons to it, and I would say maybe 5% of patients that we see are candidates, or this would be an option for. And then down below, as I mentioned, this is what a total knee replacement is, meaning we address all the compartments of the knee and remove all the arthritis in one surgery, and no arthritis can return. So as I mentioned, it's just arthritis confined to one area of the knee. It's a similar idea. We use plastic and metal components to restore the joint line and replace all the cartilage. As I mentioned, probably a shorter recovery time, but not all patients are candidates for this. So knee replacement rehab is very different than hip replacement rehab. And I'm very upfront about it. It's a much harder recovery. There's a lot of therapy that's involved, and the first month is challenging. We start therapy basically within the first week of surgery, and the knee gets big and swollen and sore, and we're asking you to bend it and straighten it and work with a therapist. And it seems crazy, but it's really important in terms of getting your motion back and alleviating your pain in the long term. By the same token, you can walk on it right away, and we want you to. You're using a walker for the first couple days, and then cane for a few weeks, usually 3, 4, 5 weeks on a cane, typically 3 or 4, and walking every 5 minutes every other hour or so, just to keep the blood flowing and keep you moving. But we do get therapy involved in the first week or two. They do some measurements and assessments on strength and things like that, and they work on bending it and straightening it. But it takes about 3 months to recover from a knee replacement. And by 3 months, it's about 90% improved. And you'll still see gains for up to a year out from surgery. But it is a contrast between hip replacement and knee replacement. Expectations are to be able to walk without pain by 3 months. The wound takes a few weeks to heal. The range of motion often takes 2 to 3 months to fully return, but by 3 months we should be there and back to normal activities in 3 months. But again, it may take up to a full year to get the maximum benefit from it. So patients oftentimes ask, when is the right time, or when should I have it done? And it's important to just consider how much pain you have, and does it affect your quality of life? Is it hurt, when you sleep? Is it hard to go up and down stairs? Are the medicines, injections no longer helping anymore, and it's affecting your daily quality of life and really making you not happy? Then it's a good time to start considering it. Another question we oftentimes get, am I too old, or what's the oldest a knee replacement can be done? And from our standpoint, or my standpoint, age is really just a number. It's really how you function, how you feel, what your goals are, and other medical issues that we kind of take into account. So I just listed some other frequent questions that we get in the office, and then we can go over any questions any of you guys have. But where do we do the surgery? We do majority of it here at Concord Hospital, probably 60% of it here. Oftentimes 1 night in the hospital, sometimes 2, depending on support system and how you're feeling. We do some at the surgery center as well for younger patients, healthier, active, that have a good support system. But it's you come in the morning and you go home that day. So it is a contrast. We almost never send patients to rehab anymore or skilled nursing homes. There's a higher risk of wound healing problems, surgical site infections, and we found over time that the care really just isn't that great a lot of the time. And so our ideal situation is for patients to go home, and if it takes another day in the hospital, that's ideal, or to have some family members or friends that can help out afterwards for a few days. Therapy, as I mentioned, sometimes we'll do in-home therapy for a few weeks until you can get to a physical therapist office. They generally do a better job in their office because they have more of the tools and things that we like them to use. And then outpatient therapy for 1 to 2 months, sometimes 3 for knee replacements, depending on how they're feeling. But as I mentioned, for hip replacement, it's not all that common anymore that we do that. Does it hurt? We use what's called multimodal pain control. So our goal is to limit the amount of narcotics that patients need because they have a lot of adverse effects that aren't great. So we maximize the dose of Tylenol we can use. We use anti-inflammatories. We encourage ice, elevation, and then we rely on small doses of narcotics if it's needed. Driving is usually a couple weeks. Everyone's different, but you need to be off pain medication and you need to feel safe. That's my answer. We can't legally tell you you can or can't drive, but you have to be off narcotic medication. When to return to work or activities. As I mentioned, you're walking the day of surgery. Most people, depending on their job or occupation, can get back to work anywhere from 4 to 6 weeks, 8 weeks sometimes. Laborers or construction workers maybe closer to 3 months. People that work on a computer screen or on the internet oftentimes can go back to work sooner. But generally by 3 months you're back to normal activities, meaning starting to get back on the golf course or playing pickleball or those sorts of things. I kind of touched upon some of the knee rehab specifics as well as the hip. The only thing I didn't mention is that with the more traditional surgeries back a number of years ago, there were a lot of restrictions. You couldn't sit on a low-seated position. You couldn't move your leg a certain way. We don't have any of those restrictions now. Basically, patients can do whatever they want to do within reason. What can or can't I do after joint replacement? You can do anything you want to do or anything you did before surgery. However, I discourage running because it can wear out the parts a little bit faster. And if you didn't do a lot of backcountry skiing before, I wouldn't recommend starting that now. But if you play tennis, the goal is to get you back to playing tennis, or you like to walk 5 miles or hike, that's the goal, is to get you back doing that. Can I kneel after knee replacement? We don't have a reason you can't. I don't have a reason you can't. It's safe for you to do. I would say more often than not, patients find it uncomfortable or funny feeling, and so encouraging a kneeling pad or guarding pad can be helpful. We're starting to get more questions about technology and robotic-assisted surgery. So there's robotic-assisted surgery for knee replacement, which has been around for a handful of years, and it's becoming more popular. As I mentioned, we used x-rays during the hip replacement. These are all tools that can help improve alignment. We haven't found that pain or range of motion or function has been significantly changed by especially robotic surgery, but we're looking at long-term impacts. And if the one thing it has shown is that there might be a little bit better alignment using a robot. Having said that, we don't know if it has any long-term effects at this point. It's a tool that we're starting to use, and just like any tool, it's on the surgeon or person putting the input in to make sure that it's all done correctly. And it's still, at the end of the day, the surgeon doing the work. The robotic stuff is just kind of giving us more information and more real-time data at that time. This is a picture of what one of the robots actually looks like. And these are just a couple myths about joint replacement. So patients with arthritis should only have conservative treatment options. That can be true to an extent, but as I mentioned, joint replacement is extremely successful, and so it's a really good option for many patients. It won't feel natural. I'd say 98% of hip replacement patients say it feels completely natural and they forget they ever had the surgery. With knee replacement, it can be not quite as natural, but the pain is gone. Many patients are too young for joint replacement. That mantra has been changed over time, and the patients nowadays in their 50s, 60s are much more active than they have in the past and have higher expectations, and so it's not unreasonable to consider it in the right scenarios for younger patients. You should wait until you can't walk anymore. I think that's risky because once you stop walking, it's really hard to get you back walking once again. And so I wouldn't wait until you can't walk. And then all joint replacements are the same. They come in all flavors just like everything else. Some are more routine and some are much more challenging and complex, but we're happy to do them all. So I see patients here in Concord across the street. I go to New London once a week as well. We have an office there, and as well as Laconia. And so I'm happy to answer any questions anybody has.
Well, yeah. I noticed on the x-ray of the knee replacement that you couldn't see the patella. Is that not bone? Is that why it doesn't
Let me go back. It's there.
It's here on the bottom. No.
So it's here. It's actually just covered up by the metal right there.
Oh, okay.
This is looking at it from the front, and so the kneecap is in the front, and you just can't see it because of this metal part, but it's there.
So what's the difference between arthritis and just kind of wear and tear on your joints? Isn't arthritis a disease?
Mhm.
Whereas wear and tear can also create pain and
Yeah.
the like.
So wear and tear is more of just a general term. It could mean you have some component of a meniscus tear. It almost always is a synonym for arthritis, though. But it can be other things. But wear and tear is almost always arthritis. Yes.
I've got a couple questions for you. I'm delighted that, first of all, that you're here today. I'm extremely excited about your presentation. There are two questions.
Sure.
You mentioned Tylenol twice,
Mhm.
and I'm not a big fan of taking medication.
Yeah.
But I've got three problems. And is there any internal effect that you can take too much Tylenol for? Because it seems to help on the knee infection, but
Yeah.
I don't want to depend on it for
Yes.
long term.
It's a good question. It can affect your liver. It's processed by the liver, so it can have some effects on the liver. And so oftentimes we'll have patients check with their primary care to make sure that their liver function's been fine. But generally, Tylenol has been a pretty safe medication. On the flip side, things like ibuprofen and Aleve, those can have effects on your kidneys. And if you're on a blood thinner, you can't take those medications. So oftentimes we'll, again, have patients check with their primary care if there's a question as to whether or not they can take it.
But it should be monitored at any rate.
Yes.
Okay. The second question is injection. Is there different types of steroid injection that you can have, that this might work, that might not work?
Yeah, so there's really good question. There's a bunch of different injections, actually. There's, the kind of the traditional injection is a steroid injection, and there's a couple different types of steroids we use. They basically all work the same. We know that they work pretty well, and the first injection or the first couple may last for 3 to 6 months or longer, and over time they just don't work as well. The more you have, they start to wear off quicker. There's a gel injection that have been marketed. There's no real scientific evidence to show that they make a long-term difference. They market it as it puts cushion back in your knee. In reality, it doesn't. It's just that the idea is that it lubricates the knee. Anecdotally, we do them, and I've had patients get a lot of relief from them, and we've done them, and patients have gotten no relief. And so we do them, but there's not a ton of evidence to support it. And then there are other things like stem cell injections, which you may have heard about on the radio or news. There's really been no scientific evidence to support doing that. It does not regrow cartilage, and it's probably some degree of a placebo effect. And the issue is it's not covered by insurance. It's extremely expensive.
Now, I'm doubly excited that you're here because you mentioned the gel. It seems like in my knees, non-medic, I've got no experience whatsoever. It seems when the knees start hurting, the lack of gel, or as my dad used to call it, axle grease,
Yeah.
put it behind the kneecap. Now, it seemed to me that a gel like that, something to make it slippery or move around,
Yeah.
make it flexible.
Yeah.
He just doesn't want the surgery.
Yeah. Yeah. It's
Working on new patients, Doc, let me tell you.
it's certainly a reasonable thing to try. It's a reasonable thing to try, and theoretically it makes a lot of sense. Put some gel in there, it's a cushion. In reality, it disperses throughout the whole knee and doesn't stay in one spot. And I would say the results are all across the board. It's not harmful. There's very little side effect to it, so it's not dangerous. I'd say the biggest downside is just not getting any relief from it.
Thank you very much.
Are there replacements made in standard sizes, or can you customize them with your body?
They're, I'd say 99.99% of the time, we have every size available. The companies, there's thousands of different combinations just with all the sizes that we have. I've never personally run into an issue, even remotely close. Patients that are 4'11", to patients that are 6'9". We have every size in between. I only hesitate a little bit because if I had a patient that was 4 feet 5 inches, I would strongly consider getting more imaging and finding out if those parts are actually going to be too big, because there are companies that make pediatric sizes for this sort of stuff. But 99.9% of the time, it has not been an issue.
As a surgeon, you want to have satisfied patients, you want to have excellent postoperative results. You indicated at the start of your talk about some of the risk factors, obesity, diabetes out of control,
Yeah.
Old age, etc. And some of those things the patients can modify or
Right.
improve on before surgery.
Yes.
How stringent are you about insisting your patients maximize their medical health before you attempt to operate on them?
We do our best to modify the things that are modifiable. So smoking is a hard cutoff. Diabetes control.
Indicating that they have to stop smoking
Yes.
before you'll operate on them?
Yes. There's a significantly higher risk of wound healing issues as well as infection. And to do my part, I think it's best for the patient to stop. And we've had a lot of success. Other things like diabetes control, patients have diabetes, that's not a hard stop. It's making sure it's under a certain number that we've studied, that we know it's safer. Above a certain number, the risk of infection is significantly higher. So we work to get them optimized, to get them into a safer position to have surgery.
But is it fair to say, you would say, yes, you need this operation, but I'm not going to do this in maybe 6 months or 9 months or something until they maximize?
The modifiable ones, oftentimes we'll work with them in their primary care to get that to happen.
And the other question I had was, on your list was dental health.
Yeah.
You didn't expand on that at all. Could you comment on that?
Sure.
How that relates to your
Yeah. So it actually comes up fairly common, but things like a patient needs a root canal, and then, a week before surgery, that needs to be taken care of well in advance of surgery, because you're going to have wounds and stuff in your mouth, or patients will have a dental abscess, and that sort of thing. So we want that taken care of prior to surgery.
And that's an absolute.
Some of those things, yes.
To expand on that a little bit, I had a hip replaced years ago, and I was told that for the rest of my life that I would be required to take oral antibiotics prior to any dental work. And I did that for a number of years. I was not able to get a prescription. I was low on the oral antibiotics prior to some dental work. I was not able to call the orthopedics department. So I called my local PCP. And PCP got back to me and said, you don't need it. They said that there's been a new philosophy on this now,
Yeah.
that oral antibiotics are only needed when, I think you said, a heart valve replacement had been done or something to that effect, but not as a general rule.
Yeah.
So is there a change in that? Or?
So the real answer is no one knows, which is really comforting. For a long time, and our group continues to do it, but for a long time, there was a study, and there was thought that anytime you have dental work done, there's bacteria that gets in your bloodstream, and bacteria likes to go to places that are foreign material, meaning the metal in your knee. And so we protected patients with antibiotics beforehand. At our national conferences every year, it's 50-50 who do and who don't do it anymore. And there's a lot of studies one way or the other. We don't have any really great quality data to support doing it or not doing it. So a lot of times it's surgeon comfort or surgeon preference.
There's been no studies done.
There have been studies done, none of them are high quality. And there's no consensus in the Orthopedic or Hip and Knee Replacement Society that we need to or don't need to do it.
So how worried should one be if they needed to have immediate dental work done, but
Yeah.
they don't have the ability to take an oral antibiotic?
Yeah, I would say in the first 3 months after surgery, definitely, probably the first 6 months.
5 years down the road.
5 years down the road, probably not as important, unless you have other medical issues out of control that would put you at risk for it.
Thank you.
Yes.
If somebody is just beginning to have knee pain,
Mhm.
what's a difficult thing kneeling? What is there that, you see the advertisements on TV and stuff, is glucosamine
Yeah.
program?
Mm-hmm.
Is that effective?
Again, there's no scientific evidence to support using it. It's a really good marketing tool, and when patients ask, I usually say, save your money.
Thank you.
Mm-hmm.
I'll save my money.
Yes.
Still hard to come by now.
When you were talking about
That'd
risk
save it.
factors, heredity. If my mother or my grandmother had arthritis, will I have arthritis?
It's the most common reason to develop arthritis. You can develop it from an injury. You know, if you dislocate your hip or you break something as a child or a teenager, you're more likely to develop arthritis. But almost always you can blame your parents.
Or just one more thing.
Yeah, exactly. Yeah. Yeah.
Gee, can't believe
Any
I
other
never
questions
said
for
that.
Dr. Desmarais? Thank you, Dr. Desmarais, for
You're
your
welcome.
time.
Thank you.
and fabulous presentation.
Sure.
We appreciate you being our guest speaker today.
Anytime.
Thank you to everyone for coming out today, for sharing this time with us and listening to Dr. Desmarais. On behalf of the entire Concord Hospital Trust staff, we want to wish you happy, healthy, and joy-filled holiday season, shared with friends and family. Next month, Dr. Ann Granfield will be our What's Up Doc speaker. She will be talking about the latest updates in colorectal surgery. That'll be Friday, January 13th. Stay safe, stay healthy. Thank you.